Good afternoon, everybody. I'm Kamal Vora, the Secretary General of Indo-American Chamber of Commerce. I'm happy to welcome all of you to this webinar on the business case for antimicrobial stewardship, achieving better outcomes and cost savings. We have this event thanks to Dr. Upasana Arora, who's our national chairperson for the National Committee on Healthcare, Pharma and Healthcare, and also to Dr. Sangeeta Sharma, who has also taken a lot of pains to put this together, especially the panel of experts that we have here. I'll just take 1 minute to go through the names of people. We have Dr. Upasana Arora, and as I said, she is the chairperson of our National Committee on Healthcare and Pharma. She is also the Managing Director for Yashoda Super Speciality Hospital. The next person is Dr. Sangeeta Sharma. She is co-chairperson of our National Committee on Healthcare, and she is also an HOD, head of department, Neuropsychopharmacology, IBHAS, and president of OSPRUD. I think she will only be able to explain the fine. Then we also have Dr. Anup Warrior, who is senior consultant, infectious disease, Esther, Medicity, Kochi. We have Dr. Sanjeev Singh, managing director, Amrita Hospital, Faridabad. We also have Dr. V. Ramasubramaniam, infectious disease specialist, Apollo Hospitals, Chennai. We have Dr. Ranga Reddy Buri, president, Infectious Control Academy and honorary professor, University of Hyderabad. And we also have Dr. Rahul Kamble, project head, AMS, Americas India Foundation. We also have the last and most important person is our national president, Mr. Pankaj Bora, who is a chartered accountant by profession. He's got his own practice and is based in Ahmedabad. So at this point, I would like to invite Mr. Pankaj Bora to give a formal welcome.
Good afternoon, everyone. First of all, on behalf of Indo-American Chamber of Commerce, I welcome you all to this very insightful webinar on the business case for antimicrobial stewardship, achieving better options and cost savings. But before we start this webinar and the technical discussions, I would like to give you a brief overview of our chamber. And our chamber was founded in 1968. Today, we are 55 years old. We have around 1,600 corporate members, and we have offices all across the country in 14 locations. We also have 38 partner organizations in USA, and we have been working for the benefit of our members and industry at large. Though our primary function is policy advocacy, we engage with Government of India, Government of USA, provincial governments of these two countries, and try to make sure that whatever policy formation is taking place, our members' views are heard and taken care of. Besides this, we have also been providing many services to our members. One of them is to organize this kind of webinars or seminars, workshops, to impart knowledge to our members as to what is happening in the industry, what is the latest. In continuation of that effort, today, our National Committee on Pharma and Healthcare has organized this webinar on this very important issue. And I'm sure this subject, which has been very carefully selected by the members of our National Committee on Pharma and Healthcare, will generate a lot of interest amongst all the participants. As we know, over a period of time, antimicrobial resistance has emerged as a major public problem of the world. In India, it has aggravated due to self-medication, availability of antibiotics over the counter, and lack of awareness about excessive use of antibiotics. So far, many countries have successfully implemented antimicrobial steward program. And if we talk about USA, almost 95% hospitals of USA have implemented this program. and they have achieved very encouraging results. I am happy to share that India and USA have entered into an agreement to carry out joint research on this subject, and I hope that the outcome of the research will help the professionals in this area to implement this program more effectively. I'm glad today we have many renowned doctors of our country on IACC platform who are going to share their knowledge and wisdom on this program, on this subject. They are going to discuss many aspects of implementation of this program with a specific focus on the cost savings. I'm sure participants are going to be enlightened with very interesting and engaging session. So without much ado, I would like to compliment National Chairperson of our National Committee on Pharma and Healthcare, Dr. Upasana Arora, and all the members of the committee for organizing this very relevant webinar and giving me an opportunity for being with you all. So once again, a warm welcome to you all, and it's over to you, Mr. Bora.
Okay, thank you, sir, Mr. Bora. It's my pleasure now to invite Dr. Upasana Arora. As we have already mentioned, she is the chairperson of our National Committee on Healthcare and Pharma. So, Dr. Upasana, welcome. The floor is yours.
So, good afternoon, everyone. And I am really thankful to IACC. And I would like to tell something about IACC also, that the Indo-American Chamber of Commerce, established in 1968, even I was not born that time, is the apex bilateral chamber, which actually is realizing India and US economic engagement in various fields of interest of both the countries. And you can see these days our leaders are really very good with each other, which is very good for the world also. So today's topic is really very good, and credit goes to my co-chair and my friend, Dr. Sangeeta Sharma. She is a master in this field, and we have several times invited her for doctors, because this is a real problem world is facing. So I think I should say prevent misuse, then overuse and underuse of antibiotics. Because if everybody will understand this quote, everybody will be aware, and then patient will be beneficiary. So I think we are doing lots of things in for this AMSP, because we need to do lots of audits, and because it's not only patient, to prevent AMR in the organism infection in the patient by reducing transmission of multi-drug resistant for patient to patient, patient to healthcare worker, and patient to attendant. So we are supposed to look after everyone, not only patient. So by identifying the organisms by culture sensitivity testing or antibiotic sensitivity PCR test, early detection of drug resistance, and sensitivity leading to precise medication, ensuring early recovery and reduced length of stay. And I must say, because NABH is an accreditation body, they are always think and see that what is the length of stay in a hospital. So in Yashoda Hospital, it is very good, 1.75 days we do. So leading to cost effectiveness, both the patient and the hospital. So patient is also happy, he is getting discharged on time, and hospital is also happy because he is getting new patient. So to prevent irrational antibiotic use of broad spectrum antibiotics, buzzword is right drug, right dose, right duration for right time. So I will not take much time because all my experts are sitting here. Half of them are my friends, few are new faces. As a chairperson, I welcome you all and really ready to listen. But I really want to tell something, that leadership role is very, very important if you want to do this stewardship in your hospital, because lots of things are depending on the leader. So I want us as a leader, this is not for doctors who are talking here. This is for those who are join our webinar. They should understand that increase awareness of doctors by conducting awareness program like antimicrobial stewardship program, like I have done with Sangeeta. Then identifying and finalization the list of restricted antimicrobials by the Hospital Infection Control Committee, which my hospital is regularly doing, motivating the doctor to use the restricted antimicrobial forms. So these things are restricted antimicrobial audit programs, identifying the list of irrational antibiotics in the drug therapeutic committee and remove from use. So we are doing it regularly and lots of hospitals are doing regularly, but still, not only in India, you will find lots of other countries are also doing, but in USA, they are very restricted, and I am really vouch for that. So with these words, I really want to hand over this wonderful program to my dear Sangeeta. You please take it forward. Thank you so much.
Yes, Dr. Sharma, please take it away. There, you can start.
Thank you, Dr. Upasana, for giving us this opportunity, suggesting this topic for this panel discussion today. And I thank IACC, for this opportunity to get arrange this panel here, to get this distinguished panel here. I think we are all set to discuss a very, very important issue today, which is not only of concern to India, but it is a global concern. And we know how important is this subject. Antibiotics are the most important discovery of this century. And we of our age group, our generation have seen the golden era, where we had one after the other penicillin antibiotic group coming after discovery of penicillin in 1928 and its marketing in 1940. We had several groups of new antibiotic classes, and which has changed the whole scenario, not only for the management of infectious diseases, but also, all our achievements today, I always say, of modern medicine are due to these antibiotics. And particularly, those of us who are here from super specialty hospital, quaternary care, tertiary care hospitals, all these surgeries, complex surgeries, micro surgeries that we are able to do, transplantation, cancer treatment, all of this is possible only because of the antibiotics. Now, but what has happened over the years is that along with the use came the misuse of these antibiotics. Everyone started using this, and over the period we've seen that there are no new antibiotics coming in, at least for last 2-3 decades. No new class is coming. You may be saying that there are every time new antibiotic is being introduced, those are generations of the existing classes only, but no new class. Mind you, this is a very, very important constraint that we have today. And over the years, we've seen that germs have been smarter than us. They have always remained ahead of us. So that, because we are overusing, misusing these antibiotics for trivial viral infections, supposedly so-called secondary infection, prevention of secondary infection, we've been using these. And at the same time, some people who need antibiotic, even the basic ones, are not available to them. So this excess versus excess paradox is creating a problem, and it fueling the problem of antimicrobial resistance. This is not a new phenomena. This is a biological phenomena, but this use in not only in human beings, but in animal sector, agriculture sector, and the environmental pollution that we have today, where antibiotic residues are found in our water bodies, and they have got into our food chain. This is, creating a problem, taking us to a post-antibiotic era. This is in post-antibiotic era, I mean to say that people will continue to die because of the infectious diseases, because the existing antibiotics are no longer working on them. And actually, this is a slow, silent pandemic that we are not able to appreciate, not able to feel it, but indirectly the number of deaths, the magnitude of the problem is much, much more than the COVID pandemic. We've all been through, our generation has seen the pandemic and how devastating it was. And we were, helpless because this COVID struck us like a tsunami. We didn't know. But we are, we are not very much concerned about this AMR issue because this is slow, silent. People don't know. It is not written as cause of death in the death summaries that we have. So many of these deaths are going unnoticed. But if we don't take a call on this today, perhaps we will not be leaving anything for our next generations. I think this is our moral responsibility because no new antibiotics are coming in and the existing one are no longer effective. We have already entered into a post-antibiotic era, and we've seen nature has always been in control. You keep reading much more these days that such and such outbreak happened, such and such, now we see diphtheria is coming back, measles is coming back. Why is this happening? Because nature is in control. So we need to really look into, how are we doing? Are we making best use of the available resources that we have? Are we able to preserve our antibiotics that we have? With this, I think background, I can open the panel discussion, and I will invite the panelists here, and let me tell you one thing about the panelists. We have a very distinguished panel here, and these are the people who have been working on this AMR right at the ground level, and they have many years of experience of working in the field, working with the patient. They exactly know what are the challenges. They have the experience of working with private sector and public sector as well. So as the drivers or the challenges may be different between the two sectors, but the problem remains the same. And the solution to tackle this problem remains the same. May I now invite first Dr. Sanjeev Singh. He is working at Amrita Hospital. He's managing director. He's very active implementing AMSP programs. Can you, tell us how does this AMR impact patient outcomes and healthcare costs? And what has been done at Amrita Hospital to take care of this problem?
Sure. So I would like to thank Indo-American Chamber of Commerce, Kamal Voraji and Pankaj Voraji. Thank you so much for the invite and organizing such an important deliberation. And thank you, Dr. Sangeeta and Dr. Upasana Arora, for chairing this session. So very relevant question and what all has been done. So unfortunately, everything we generally present it as patient lives being saved. If it is converted into rupee terms, it makes a huge difference. And I'll give you an example. Somewhere around 2010, when we were doing our infection prevention practices, and I had, it's a 1350 bed hospital. I had only one infection control nurse. Once, and then there was a lot of work which has been done to sort of put processes in place and measure outcomes. Once though we saw some great dividends, but once we converted this into rupee terms, so my surgical site infection was 55,000 rupees, my ventilator-associated pneumonia was 79,000 rupees, and my urinary tract infection was 29,000 rupees at that point of time. And I just implemented a good hand hygiene practices in one of the most difficult department, which is cardiovascular thoracic surgery department, because it's considered that they are always above God. And if you could sort of achieve it there, it's going to be sort of achievable at other locations. So in one department, 1 year, back to basics, hand hygiene, my saving was close to 1.8 CR. And when this was presented to our group medical director, I basically then got 8 infection control nurses, because you make that change once you convert your processes and outcome into rupee terms. So your question whether what would be there as a patient outcome and whether it makes economic sense, it makes huge sense. Now let's come to antimicrobial stewardship practice. So unfortunately, this practice also, as you do, you get sucked in and you get deeper. So we were doing antibiotic stewardship, we realized tubercular is important. We did anti-tubercular, we realized antifungal is important. We did antifungal, and then we realized diagnostic is important. And when we did that throughout the hospital, we do realize that there is a morbidity, mortality, and cost of care reduction. My length of all-cause mortality was down by 1.2%, and my length of stay was 2.9%. Now, 2.9, if my revenue per operating bed is close to 48,000 rupees, and if I'm getting throughout the hospital with 2.9 days of saving, that's phenomenal. And it was close to 2.2 CR, where a good antimicrobial practices gives me a cost saving of 2.2. Now, this may not be complete saving for the hospital, but the bills of the patient gets reduced, and that brings in lots of trust in the system, and they coming back for adequate follow-up. So, in brief, a good infection prevention practice is important. It is huge cost benefit. It's huge cost effective. It is hugely cost utilized. A good antimicrobial is almost similar. There is a decent mortality, all-cause mortality reduction. There is a good morbidity reduction and a good cost of care saving. And I think it should be practiced. So over to you, madam.
Thank you, Dr. Sanjeev. But one question to you, these savings are not so obvious actually, how did you calculate this? Because directly you cannot attribute these savings to these interventions that you spent on infection prevention and antimicrobial stewardship program.
So I think that's a very good question. Basically, you'll again look at the direct and the indirect cost and length of stay and opportunity cost. So if you look at the direct bill of the patient, so it would be based on the consultations, the stay, and the pharmacy and the consumables and other logistics which have been used. So that's basic direct, and provided some of the procedures which has also been done. What is also very critical in this is an indirect cost, because of surgical site infection, where my length of stay increases by 12 days, the attendant also has a job lost days and also stays extra, plus the lodging and the food, including the job loss days for the patient. So that's an indirect cost. If you save your length of stays with a good practice, so it's basically retrospective and a prospective calculation. So if my revenue per operating, which for a very decent hospital would be close to 20, and a very good hospital would be close to 56 to 80,000 rupees. So that's a very, very good saving. Moment you are saving this, you are able to do more procedures. So we were able to do in the next year 80 more surgeries because we saved that kind of length of stays, patient days. So 80 more surgeries brings a new opportunity cost. So that's how grossly it has been calculated and presented.
Yeah, that's good. Average length of stay, I think, is the key indicator that you are looking for. And if we are able to reduce these infections and healthcare associated infections, we can certainly reduce. Can I take this little further? Any particular constraint that you found, or resistance, or from the various key stakeholders in your hospital?
So this is full of challenges. Everybody would like to resist, because it's again coming back to good practice. So one is that you have to have good data. Unfortunately, a very good, meaningful data is not there. Unfortunately, good education and training practices are not there. Though now there are many fellowship programs and many training programs which are there. There is a community is it's just not hospital acquired, because unfortunately it is there in the community. So with any hospitalization, any procedures, when they come in, get admitted, you also get these bugs. Over the counters, they are available. There are lack of regulation. Like we worked with government of Kerala and we wanted to have a mandate regulation of banning over the counter drug and getting H1. But then there were only 13 drug inspectors for 14 districts. And if anybody goes on leave, they are unable to manage. And per district, there are close to 37,000 pharmacy outlets. And who's going to regulate this? So that's again a problem. There's lack of standardization of the lab. When we did this whole practice analysis, even in Kerala, there were close to 87,000 labs. Only 48% of them were just run by microbiology technicians, and they were giving reports. So there are huge, and then there is inequitable distribution between global north, global south, access, supply chain. So there are lots and lots of constraints. Prescription autonomy is one of the biggest, because just telling the doctor to say that this is how it has to be practiced, or you cannot write this or authorize, it becomes a huge issue because he doesn't like that. And as Dr. Upasana said, and you also said, leadership and a good strategic management plan is again sort of lacking. So those are all decent constraints for a good antimicrobial practices.
Yeah, thank you, Dr. Sanjeev, for setting the scene. I think many of us, although the situation is appalling, the magnitude is very high, but there are solutions, and these solutions work. And one living case of this is Amrita Hospital under the leadership of Dr. Sanjeev Singh. Now, can I move to Dr. Anup Warrior? He is an infectious disease specialist. He's working as a managing director in the Aster Healthcare, and he's very, very active involved in the AMR program of Kerala State. Doing a lot of courses, esteemed fellowship program, has certified AMSP implementation from Redbound University, Netherlands, and so on. I think I can go on describing his achievements. Since we are here, I would like to ask you, can you elaborate on various AMSP? What is AMSP? What is the objective of AMSP? And how does it help in optimizing patient care and safety while reducing risk of AMR?
Good afternoon. Just to correct, I'm not the managing director. I'm just the medical.
For me, I made you managing director of the entire change.
Okay, so coming back to this, so when we talk about antimicrobial stewardship and antimicrobial stewardship program, so antimicrobial stewardship program is a structured and strategic approach to how various interventions, which are components of your stewardships, are implemented, monitored for their effectiveness, and the way you are able to take it up to its goal. So when we talk about just stewardship, it is just about having a list of possible interventions which are available out there. We select those interventions which are feasible or meet the requirements for us on the ground, and we try to do it subsequently in our clinical practice. But when it comes to the programmatic aspect of it, that's where more of leadership and strategy is required, because we need to put this whole into a very structured format, which means it is not just having a bundle of things which different people do at different areas in the hospital. It is about doing this in a very systematic way, have systems incorporated for monitoring how interventions happen, how it is implemented, how it is affecting the patient outcome, like what you mentioned. If length of stay is a parameter, which then how does it affect length of stay? And also having a vision on the goal. Where do you want to achieve? Where do you want to take your program in 6 months, 1 year, 2 years, etc., etc. Now, from my perspective, the antimicrobial stewardship is a core clinical activity, and the goal and the focus of it is better clinical outcomes and patient safety. The AMR benefit is only a byproduct which may or may not come in short term. In my experience, the way the prescribers or the clinicians look at it also, if you change its perspective to a core clinical activity rather than a quality initiative to reduce AMR in the long term, it much better serves the purpose. So the goal of an AMS or antimicrobial stewardship program should be clinical outcomes, because end of the day, it is ensuring good clinical practice, like what Dr. Upasana was mentioning about the right drug, right dose, right duration, right patient, etc., etc. All tenets of basic good medical practice. We obviously want the patient to have the right diagnosis. We obviously want the patient to get the drug which is appropriate for his diagnosis. We don't want to overtreat or undertreat anybody, because it's again good clinical practice. So all what we talk about in this is good clinical practice, and the way we give feedback and interact and engage with clinicians also is with this perspective, that this is good clinical practice which you are doing for the benefit of your individual patient. So that's how, in my perspective, I would place antimicrobial stewardship in the hospital environment, and also how would I place or consider antimicrobial stewardship program again in an organizational perspective.
Could you, Dr. Anup, could you elaborate on what all interventions could you introduce into your hospital?
So while there is a whole list of interventions which is available in the global literature, couple of things which have been found to useful both in my setting and also in different literature available out there, is that the most core strategy which we successfully run is the prospective audit with feedback, where there is a review of prescriptions over 24 hours, and there is a feedback which goes to the prescriber, with a caveat that the feedback is real time and the discussions are real time, and the interventions or the changes which has to be made is also real time, so that it is implemented. It's a bedside activity which happens at real time when the reviewer visits the patients and does a chart review, so that the changes are implemented then and there itself. So for example, if there is a drug error or something does not match the blood culture report and has to be changed, obviously it cannot wait for 24 hours, or we give the feedback after 1 week or a month on a compilation basis. So this now technically this is now called handshake model, and that's what we have been practicing since many decades now in terms of the stewardship activity, and one of the core programs or interventions which we do. What is the flip side of it? The flip side of it is that you need people on the floor. So unless you have people on the floor who are able to walk down and interact with the clinicians, participate in their rounds, follow up on the cultures, so it's time intensive, it is people intensive. So we need to have people on the floor who does this on a regular basis and who's able to interact with the clinicians subsequently, and over time they get the clinicians respect, and hence the compliance, and hence better adherence to the interventions and what we expect them. So that is one strategy which has been successful. The second basically is about the formulary restriction at the hospital formulary level. I'm not talking about not dispensing or dispensing. I'm talking about the hospital formulary, which is run by the PNT therapeutic committee of the hospital, not promoting irrational combinations. Okay, I'm talking about that level, where the hospital formulary itself does not have irrational combinations. Or going one step forward, you can look at possibilities where you don't want your hospital formulary to store drugs which are not there in your antibiotic policy at all. So I do not subscribe nor follow the formulary restriction at dispensing level. That is because we do not have 24/7, 365 days competent person who can assess the patient's clinical status and make a decision on whether this drug to be dispensed or not. Nor do we have any person even who can look at the so-called antibiotic order form on just and make a decision based on. Through my career, where I've been with AMS for now about 16 years or now, I've never seen a hospital where the pharmacist has refused what the internist has written as sepsis, and I want to give colistin, and the pharmacist, no, this is not sepsis, I will not give colistin. So all these order forms, I don't see them working or serving their purpose at all. So I do not subscribe to the formulary restriction at the dispensing side. My formulary restriction is at the pharmacy procurement side, not at the dispensing side. And finally, the third important intervention which has been worked and which I think does a lot of sense for me is the diagnostic stewardship aspect, where nudging the clinicians into simple things like not doing urine cultures when it is not required, or from the lab having interventions in place so that the clinician does not act or initiate an antibiotic based on a colonizer or as a contaminant. Right. So that is again being quite effective in when you look at overall reducing the consumption or prescriptions or the antibiotic use pattern. So in summary, this will be the three core interventions which I have found to be useful: prospective audit with feedback in a handshake model, formula restriction at the procurement level, and diagnostic stewardship with the lab and the clinical level.
Dr. Anup, you said real-time feedback to the clinicians where the action is needed. I know it's a very important observation that you have made, but looking at the current scenario, earlier days, many of the people in the participants also would appreciate that earlier there was a culture of ward rounds. But nowadays, the practice is shifting to individual consultant rounds, and one consultant coming and saying, okay, you start with this medicine, the other consultant coming and saying, oh, no, this is not needed, or you cut short, or you, extend the duration of antibiotic. How do you overcome this? I know this is a very important aspect of implementation of stewardship program in a hospital. This one single intervention, which does not need any other resource allocation, except that you need a culture of rounds. How do you, create that in your hospital?
So we are not looking at or even expecting to have a common timing for everybody, or we don't, and it doesn't happen on the ground, and we don't expect it also. So on the ground, what happens is that every day we have a work list of those patients who have to be followed up from the stewardship perspective. Who are those? They are who have had a positive culture report in the past 24 hours. They are those patients who have a prescription of a restricted antimicrobial or a select list of antimicrobial in the last 24 hours. So you have a work list. So with this work list, when the clinical team reviews these patients and just does a prescription review along with a clinical review, and there are, as you told, decision to be made, we call up and talk to the primary consultant. So in my setup, the primary consultant is responsible and is the decision maker for all the medications, all therapeutic decisions, all diagnostic decisions for that patient. And he's obviously also the legally represented person for that patient. So we or our team speak to the primary admitting consultant, who is the decision maker, and the changes where they are required. Sometimes it may be even diagnostic changes. Like we may say that you need to send this serology also, you need to send this also because this is what it looks like. So, or it might be therapeutic changes like change in antibiotic dose, duration, whatever. So these are communicated to them. Mostly, it is only in the intensive care setting where we have on the floor 24/7 intensivists that it's actually a bedside room. So intensive care units is where you have a true bedside round where both the intensivist and our team are together at the bedside. In the wards, it is a telephonic call to the primary admitting consultant, and the discussion actually happens through that.
Okay, that's good, because a lot of other stewardship interventions have been advocated pre-authorization. Any experience about pre-authorization?
As I told you, pre-authorization is a preclude to formulary restriction at dispensing, and we don't do that.
I think formulary restriction is a very, very good managerial strategy where, one intervention at the management level that you decide the drugs or the antibiotics which will be available according to different areas in the hospital. Okay, such and such antibiotics will be only available in the outpatient department, and such will be available in IPD, such will be available in the ICU. So working with that list, keeping in mind the WHO classification of aware classification, excess, watch, and reserve group. So if you allocate these antibiotics according to this categorization to different patient care areas, this works really very well. Particularly, it works very well in public sector hospitals because, for example, cefixime is one, and cephalosporin, which has a great potential for development of resistance. But if you, don't follow these restrictions, this is freely available in the outdoor department. And we can imagine the resistance, the acceleration of resistance caused by this overuse of cefixime, that not much time passing, we'll find that resistance has developed to this oral cephalosporin as well. So I think these are two very take-home messages, which works well in the hospital setting. I'll come back to you, Dr. Anup. Meanwhile, let me go to Dr. Ramasubramaniam. Can you also share what all AMSP activities were implemented in Apollo Hospital and what worked well for your hospital? I'm asking you this question because, each hospital is different. It has its own culture, ethos, the infrastructure. So, same intervention may not equally work well in other, sometimes it is difficult to emulate or implement that at the other health facility. Could you please share what, is your experience at Apollo Hospital, Chennai?
Yeah, good afternoon, Dr. Sangeeta, and thanks to Kamalji, Pankajji, and to you, Dr. Sangeeta and Dr. Upasana, for this invitation. I'm going to take a minute or so to just set the context a little clearer, because I see there are a lot of non-medical people here. So just for their benefit, please bear with me that antimicrobial resistance is a phenomenon which happens in bacteria, whereby they develop a resistance to grow in spite of being exposed to antibiotics. Normally, bacteria die when they are exposed to antibiotics, but if the bacteria, due to a mutation or a change in the genetic structure, is able to survive the antibiotic, it is called resistance. So this is not seen in humans. The antibiotic resistance doesn't mean that the human being is resistant. It only means that the bacteria is resistant. And this resistance development is inevitable. Resistance development is an evolutionary process which is inevitable. And antibiotics, when they are exposed, when bacteria are exposed to antibiotics, the antibiotic selects out the resistance and thereby increases the chances of developing resistance. So in 2007, the CDC and the US came up with a host of interventions which they termed as antimicrobial stewardship initiatives, which basically means doing a lot of things to ensure that you use the correct antibiotic at the correct dose to the correct patient, the correct way of administration, ensuring that you bring it down as soon as you get the culture reports, and also that cultures are sent properly, the diagnosis is done. So you do a lot of these which have been given the umbrella of antimicrobial stewardship. Now, what we need to understand is this antimicrobial use culture, the way it is used, the way it is selected, the way it is performed differs in various in different countries. In countries like the US or the UK or Canada, where there is a national health department, the rules in the hospitals are laid down by the policy of the government, and they are bound to follow these mandates, as we call them, as part of their healthcare delivery. So it is reasonably easy for a country where the health system comes under the umbrella of the government-sponsored program. Whereas in India, the antimicrobial stewardship initiatives have a completely different meaning because of various reasons. I'm saying this because unless you identify what the problems are, you're not able to come up with a good intervention with regard to a stewardship solution. The first thing is most hospitals in India are private owned, they are corporate, and they make it's a business, and they make money out of two things mainly. One is the pharmacies division, where they gain margins by getting the drug at a low price from the manufacturer and then selling it at the market MRP, whereby they make money. And two, they do a lot of investigations where they make money. So the primary business of a corporate hospital, though it is involved with treating patients and doing a good job, does to a significant extent is affected by the inherent necessity to make business money out of it. So they run for profit. And when you bring in an antimicrobial stewardship program and say that because of this program, you use less of these expensive antibiotics and more of cheaper antibiotics, it doesn't make any sense to a hospital to do this because they lose money. So first of all, you have to realize that hospitals, if they follow what is strictly necessary as part of the antibiotic stewardship initiative, will actually, it is detrimental to their survival and their making money. Two, the prices of the antibiotic also differs significantly in different countries. To give a simple example of two drugs, one is amoxicillin and the other is ciprofloxacin. And based on antimicrobial stewardship initiatives, the amoxicillin should be used more often than ciprofloxacin for every patient. This is a tablet which they buy outside. So the hospital doesn't make a very big margin of money. Whereas in India, in the US, amoxicillin is priced lower, ciprofloxacin is priced much higher, so that it automatically makes sense to use amoxicillin rather than ciprofloxacin. Whereas in India, it is a reverse. You get a ciprofloxacin for say 5 rupees and you get amoxicillin per day course of about 30 rupees. So for a patient, it doesn't make sense to buy amoxicillin paying more when ciprofloxacin, which is less expensive and works better, even though it is actually detrimental to the society and community because it increases the possibility of resistance, it makes more sense for the patient to spend money on ciprofloxacin than amoxicillin. This is unique to India. The third problem is that getting patients to have investigations done is a huge challenge in India because investigations cost money. It is cheaper to take a tablet assuming that I have typhoid than give a blood culture, confirm I have typhoid, and then take the medicine. Because the blood culture is several hundred times more expensive than a cost of a treatment for typhoid. So for all these reasons, it becomes very difficult to enforce antimicrobial stewardship and to find out what would be the current intervention. Dr. Sangeeta wanted to know what is successful in Apollo. And I start with the caveat that what is successful in Apollo may not work in Maulana Azad Medical College, which is a government college. What is successful in Apollo may not work for, say, a district hospital or a private hospital in a second-tier city, which is different. So in other words, you need to understand the culture, you need to understand the practices to ensure what works better. I completely agree with Anup when he said that the restriction of high-end antibiotics will not work in private hospitals in India because it questions the authority of a consultant. And unfortunately, in India, the use of antibiotics is a highly emotionally charged decision. So if I ask my colleague, saying that why did you use meropenem when you could have easily used, say, cefotaxime, he takes umbrage. He is very upset that I questioned him about the choice of the antibiotic, which he in his experience and knowledge has used. So it is not a question of a professional decision. It becomes something very personal. So restricting a drug in India in a corporate hospital will not work. It will work in a government setup where you say a senior registrar can use this antibiotics. If the next level of antibiotics requires approval, it will be an assistant professor. If it's a higher end antibiotics, it will be the professor. And if it is really a top end antibiotics, it could be the head of the department. That will work in a government setup, not in a private hospital. So as Anup Warrior said, in my hospital, which is a corporate private hospital, we don't have formulary restriction. We allow everybody to use antibiotics, but they have to justify when they start the antibiotic. The fact that they have to justify in a form why they are using it itself actually discourages them from using a high-end antibiotic. But if they still do, we insist that cultures have to be sent before the antibiotic is started, and they have to justify after 48 to 72 hours when they get the reports of the culture, can they continue this high-end antibiotic or use a less expensive, more focused, narrow spectrum antibiotic? This is what we found very useful in our hospital because it gives the clinician the authority to use whatever he wants. At the same time, he has to justify it and he has to review it in 48 to 72 hours to continue the antibiotic. So this is probably one such thing. The other intervention which we found very useful in our hospital is the appointment of somebody called the antibiotic nurse. Pharmacists are the people who are generally used in all countries, including several hospitals in India, including Dr. Sanjeev Singh's hospital, where they use a lot of pharmacists, clinical pharmacists. But sometimes we find that the doctors feel a little threatened, again, the same way when a pharmacist asks them, whereas a nurse is able to converse with the doctor better, because the interaction between nurses and doctors in India has been there for several centuries, and it is much more mutually acceptable. So if the nurse asks that we train a nurse on how to, look at the various high-end antibiotics and ask the doctor, has he sent the cultures? Is it all right if we can probably stop the antibiotic in 48 hours or reassess if it is a prophylaxis or modify the antibiotic? So the discussion becomes much more easier. So having an antibiotic nurse in my hospital, I feel, has made a lot of difference. So these are the two initiatives I would say, which again have to be customized to suit your institution, in your city, in your country, to get the best results. You cannot do what US CDC is saying, cut and paste it in Indian scenario and say, this is what you should do. I don't think it will work. Dr. Sangeeta, you are muted.
Yes. Thank you, Dr. Ramasubramaniam, for sharing your experience. And I think you have raised two very important points, that AMR, is a biological phenomena. We cannot stop it. We can only slow down this process, and the use is the key driver for AMR, acceleration of AMR. If we are able to optimize the use of antibiotics, perhaps this process will slow down. Second is technical issue, diagnostic facilities that are available, and the irrational rationalization of by the doctor as well as the patients here. Many of the times now in today's era where that we see defensive practice is there. I don't want to falter on the wrong side. I interact with a lot of clinicians. Why did they prescribe antibiotic when they knew that this is a viral illness? This will get better, self-limiting illness get better on its own, but they still went on. One is that they could not make out the difference between viral and bacterial. Secondly, even if they could, they didn't. If somebody else will start it, if I don't do it, patient will go to someone else, he will start. Or maybe if there is some litigation later on, something goes wrong with the patient, who is going to take the responsibility, accountability for this? So that's another very, again, but this is you'll agree with me, this is more of a attitudinal, is this an attitudinal matter or a behavioral issue, or, something really very pertinent on ground? Third thing that he brought out is regulatory issue, pricing issue. The example he gave, the second example is cefazolin, which is recommended as a perisurgical prophylaxis. This is costlier than the ceftriaxone, cefotoxime. So again, it goes into the favor of using the least, or the less costlier antibiotics than the overpriced one. We are taking up this issue with the regulatory authorities, because there are many dimensions to this AMR problem, but I thought these are the three major issues which are, we need to be tackling about. I'll come back to you, Dr. Ramasubramaniam, with the second round. Meanwhile, now I move to Dr. Rahul Kamble. He's a microbiologist. He's working as a team lead with Americans. This is again a non-government organization. He left his full-time job to work with this NGO, and he has the recently he has completed a 3-year project of working with the secondary care hospitals. Right now we heard from the quaternary care and the tertiary care hospitals, but he has worked very closely at the ground level, implementing this AMSP program in the secondary care hospital. Again, could you share your experience? What are the problems, that you face? And what is the outcome first? What are the results of this 3 years of hard work that you had done?
First of all, thanks to the team of IACC for giving me this opportunity. It's indeed a great pleasure speaking at this esteemed platform. And thanks, ma'am, for the kind introduction. I'm always excited to share the outcomes of our project. I left full-time as a consultant position at from Lilavati Hospital, Mumbai. And for my passion of antimicrobial stewardship, I joined this organization and undertook this project at a greater level. Under my project, we have 11 hospitals. These are 200 to 300 bedded hospitals spread across 7 states of India. So in each of the hospitals, we have a clinical pharmacist, PharmD qualified, an inpatient control nurse, and a medical officer. As per the literature review, in this fight against antimicrobial resistance, antimicrobial stewardship is not only the tool. There needs to be a comprehensive or a theragnostic or a holistic approach against this fight of AMR. So in this project, we deployed inpatient control nurses, medical officers, and clinical pharmacists across each of the hospitals. The challenge that we faced while we enrolled this project, that very few of the hospitals had little to no data regarding the pattern of infections and the pattern of the pathogens spread across these healthcare settings. So we said as eyes cannot see what the mind doesn't know. So diagnostics was the eye opener. We equipped this healthcare settings with the diagnostics, wherein it was not possible or feasible to start with the diagnostics. We leveraged we strengthened the gap between the outsourced lab. And then with the help of the diagnostic stewardship, we were able to gather the data regarding the rate of infections and the rate of drug resistant pathogens. Using this data, we developed the antibiogram, antibiotic policy, and understanding the cultural and behavior pattern, and using this data with a mutual consensus, we set up the SOPs and protocols. We established the stringent monitoring evaluation mechanism across all these healthcare settings. And the key performing indicators that we used for this to evaluate the impact of this project were, first was the improvement in the knowledge, attitude, and practices among the healthcare professionals. The second was the improvement in the compliance towards the inpatient control practices and antimicrobial stewardship policies. And thirdly, reduction in the rate of antimicrobial consumption, reduction in the rate of multi-drug resistant pathogens, and reduction in the rate of hospital-acquired infections. And what we observed, thanks to the leadership support and to the support of all the good support across all the categories of healthcare professionals of the settings, we observed around reduction about 24% reduction, on average of 24% reduction in the rate of multi-drug resistant organisms, and an average of about 13% reduction in the rate of antimicrobial consumption in terms of defined doses, and about 30 to 60% reduction in the rate of hospital-acquired infections across all these healthcare settings. So that was about the outcomes of the about the project. To start with, it was very difficult for the first six months. Things were going very manual. Antimicrobial resistance or stewardship programs carries a huge data. So thanks to the leadership support, we were able to integrate digital data analytical tools in the hospital information system, and that helped us to analyze this data and get the results.
Thank you, Dr. Rahul, for sharing your experiences of implementing this program in the secondary care level. What, according to you, was the most challenging thing of implementation of this program in these hospitals?
First, I said I was about the diagnostics. Second was about the compliance towards the protocols. There was a huge challenge from the clinical and the paraclinical parts to the compliance towards this AMR protocols. So we solved it. We dealt with this problem by involving these clinicians and the paraclinical healthcare professionals. We involved them in our, made them part of our teams and committees, engaged them, helped. There was aggressive trainings done for those healthcare professionals, and which helped us to deal with those challenges. Also, other challenges was about staff attrition. We conducted more than 4,000 training sessions across this 2-year period. The training was one of the key intervention. Without knowledge and without understanding, because SOPs and protocols it's difficult. We conducted exclusive trainings and audits also. It was not like a point prevalence survey, but it was daily audits by the pharmacists and nurses to see the compliance towards the protocols. And so trainings and audits helped us to deal with the challenges in our program.
I think the two major take-home, messages from his work is that you need to collect data and then also to educate the providers or the prescribers here. There is a huge amount of cognitive deficit here. People have the knowledge. When you do this CAP, I'm sure your results would also be the same. Knowledge is there, what to do, what is ideally required. But when it comes into, translating this into practice, then it goes by the experience or the peers may influence, so I think certainly education is an area where we need to, educate, continue doing it. For those of you who are, are the CEOs or the managing director or MS of the hospital, one thing take home is that continue doing education. That's the answer. Okay, I'll come back to you. Meanwhile, Dr. Ranga Reddy has been waiting for quite long, but I will ask you a difficult question now. Okay, what are the policy level, initiative? How do you think you've heard both sides? Secondary care, tertiary care, quaternary care, it benefits. We know the benefits of this program, but how do we do this at a policy level? How do you make people adopt this at the clinical level?
Thank you, Dr. Sangeeta. Thank you, IACC. Thank you, Dr. Upasana, Mr. Vora, all of you, my colleagues who are present here as co-panelists. A very good evening to all of you. There is a big problem in terms of translating some of our learnings into policies and then those policies into interventions. This always had been a problem. Either it is at a global level or at a national level. This had been a big lacune in terms of the whole cycle, how it had to evolve. So when we talk about policies, definitely they are instrumental in empowering antimicrobial stewardship programs, or for that matter, any other program, in terms of mitigating the risks which are associated with the antimicrobial resistance, as all of you have said, a big problem, a big menace for the humanity. Without a policy, taking up anything is like navigating an ocean without actually a compass. So unless we are going to have a robust policy which is based on the evidence, we will not be able to have the right kind of interventions and right kind of actually implementation. But even before going into how this is translating into policy, what kind of policy actions, interventions, in a simplified context for the people who are non-medicos here, right? The stewardship in relation to AMR in a very, very simplified way is about managing the use of antimicrobials so that it's safe and at the same time appropriate, right? So if that is the context, currently the responsibility of this stewardship most of the times falling onto the clinicians, right? And the clinicians are having a tough time because there is no enabling environment in order to make the implementation, in a way how it is optimal, where they can actually cut down on this usage of antimicrobials. The situation, in terms of the enabling environment, it further gets, worsened when we look at, non-medicos or so-called, quacks, kind of prescribing the medications, especially the antimicrobials, and also the dispensing of the over-the-counter, all the kind of antimicrobials. I think Dr. Sanjeev has very rightly mentioned. It is practically becoming impossible actually to stop this menace called as over-the-counter dispensing. It is also well known that the use of antimicrobials outside hospitals is quite high. In a country like India, probably we can easily estimate it to be more than probably 60%, right? It is also found mentioned in the WHO Director General's report recently, that was the last month, in the 77th World Health Assembly meeting, where I probably would quote DG, the Director General of WHO, who said, within the human health sector, the implementation of national action plans is often fragmented and limited to hospitals. Despite most antibiotic use being outside the hospitals. And that is what is the scenario, right? So why I am talking about is this particular aspect is we had to look at even the antimicrobial stewardship much more holistically. If we don't do that, we are going to fail. If we want to achieve outcomes, our focus should be on implementation of the policies at national, state, and even at a local levels with strict regulations to monitor and regulate the entire chain from manufacturing to usage, not just prescriptions at the hospital, doing the prescription audits, and all that what our colleagues have mentioned. Of course, having said that, I don't want to downplay the role of hospitals and the clinicians in overuse. Definitely it is there. And I am painfully aware through the survey of NCDC, which has been published probably about a couple of months back, where they have done the survey at about 10,000 patients in various hospitals across India. The kind of data which they have given is quite alarming, and this particular report has revealed that 55%, that is a staggering number, antibiotics are given as preventive. That is where all the problem lies. And only 6% of the prescriptions with confirmed bacterial infections. Again, colleagues talked about, the lacunae in terms of the diagnostics and not effectively using the diagnosis and diagnostics and the diagnosis as a basis actually for the treatment. If we are going to continue with that, definitely we are going to end up in much more bigger soup than what we are in today. We should be mindful at the same time that if we are going to give a very aggressive push of antimicrobial stewardship program without the capacity to prevent, diagnose, and treat the bacterial infections and the drug resistance and the evidence base for policy development, that would be, in my opinion at least, a counterproductive measure. It will lead to clinician frustration, and over a period of time, people like Dr. Ram and probably my other colleagues like Dr. Anup may get frustrated. They will become cynical because there is no enabling environment to practice the antimicrobial stewardship. So, and hence, one of the major areas in terms of the policy direction is we had to expand the scope of antimicrobial stewardship program, making policymakers, manufacturers, even the pharmacies and also the patient stakeholders within this particular program. Otherwise, probably it would be very, very difficult. We also need to recognize and integrate antimicrobial resistance interventions in health systems and interdependencies with our health system capacities. And we had to certainly set this as a priority for universal health coverage or the health emergencies which we have just passed through. But when I said all these things, let me not, sound too pessimistic. Not that everything is bad. There are a lot of good things happening. I can actually, count on some of those policy directions or the interventions which are happening good at even at India level. I'm not talking about a global level. You all would have, especially those who are in practice, would have seen Dr. Amit Goyal's directive, the Director General of Health Services, which was, as early as January 2024, where, he has made the appeal, and also probably the directive we had to mention, that it is a mandatory practice to write indication while prescribing antimicrobials. This is a huge step in the direction of AMSP and also the containment of antimicrobial resistance. I can go on such good practices like Kerala, Andhra Pradesh, and even Telangana have made over-the-counter dispensing as a criminal offense. That's a very good thing, which is happening. And, the states like Andhra Pradesh, where I am steering the state action plan, have completely banned the antimicrobials in aqua sector, right? So all these things are happening, but at the same time, it is being done in a very compartmental level. So we need to integrate all of them. We need to actually flow them into the policy. And probably, since there are a lot of people who are also part of the National Action Plan and also the various state action plans, we together need to at least do two, three things, in my opinion. One is, of course, update evidence-based guidelines, prescription guidelines. We had to make them up to date. And we had to make a uniform policy across India. Otherwise, we are going to miss out. And that unified policy had to be based on the surveillance, evidence, antibiograms, etc., etc. And third thing is the regulation to restrict sales of non-prescription antimicrobials. We know that, a lot of creams are being sold where antimicrobials are being mixed, etc., etc. I think at least, few things we had to get these things right. And some of the good learnings from some of the states had to be made, kind of prescriptive for other states also. I think I will stay here now. I will expand it a little later. Thank you, Dr. Singh.
Thank you, Dr. Rangareddy, for nicely elaborating on the multi-sectoral, multi-dimensional, multi-stakeholder problem. I know since the canvas is so wide here, used in human sector, non-human, and that continued conundrum: who is using most, who is not using over the counter. People think that you go and set this first right, then we will do it. I know it's all there, but getting these regulatory people buzzed is the most difficult task. Recently I was interacting with them. They live in ivory towers. They don't know. They think the regulation is okay, but what they are least bothered about is the implementation, and they always talk about shortage of inspectors and all that. But still, we are continuing our efforts here. And definitely one thing I think he laid very importance on having this document policy in place, not only at the national level, state level, but at the institutional level. And since, I was talking about, particularly maybe I refer to institutional level here, is this policy rule book is very important. What is the rule? Who is going to do what? Doctors, nurses, pharmacists, what is their role in it? Many times when I spoke about this antibiotic nurse, Dr. Rama Subramanian, when I started talking about it, many people asked me, what is the role of nurses? They don't prescribe. It is the doctor who is prescribing. They just have to administer it. Then I had to really go on and on, explaining to them that nurses can ensure that the cultures are taken prior to the first dose. They can ensure that the antibiotics are administered in a timely manner, reconstitute them properly, take those culture samples properly, because most of the time diagnosis is not arrived because of these small little problems of collecting samples, storage, transport, And then even if you have the report with you, the culture report with you, either we don't look at it, or if we look at it, we don't know the interpretation. So it does not get applied. So I think it's a multi-dimensional problem in this panel discussion. We could not take up all the questions, but very relevant. That rule book should be there. Okay, with this, I will move to the second round. Knowing these problems at the ground level, may I ask Dr. Ramasubramanian, why antibiotic is not the only solution? Somehow we have felt that antibiotics are being used as a shortcut for everything. Shortcut for diagnostic if you are not able to arrive at a diagnosis, shortcut for communication because it takes time for the doctor to explain to the patient, shortcut for any shortcomings in infection prevention and control. So but we all know that antibiotics are not the only solution. Can you just elaborate on this?
Yeah, I mean, it seems intuitive that you say that antibiotic resistance happens. So if it happens, just bring in a new antibiotic and invest in research so that we keep churning out newer antibiotics to fight the problem of antimicrobial resistance. But unfortunately, you have to look at the reality to understand this is not a workable solution. Now, the first thing is, quoting Garrett Hardin, who in 1968 in the American Journal of Science termed the tragedy of the commons. During the Victorian times, commons were the common areas of grasslands, which the government said anybody could use to benefit. And they found that when a person is given access to a public resource free, he uses it to the maximum benefit. And in the end, that resource goes waste. So similarly, antibiotics are a resource which they are miracle drugs. They have worked wonders. They have reduced mortality significantly, morbidity significantly. So, but there is no onus on the antibiotic. Any specialty, you look at, say, dialysis, the nephrologist deals with the dialysis. If you look at, say, an endoscopy, the gastroenterologists take charge and they are the ones who deal with it sensibly. But antibiotics can be written by anybody who's an MBBS. Actually, you don't need to be an MBBS. Even now, Ayurvedic doctors, homeopathic doctors use antibiotics left, right, and center because they've made a big difference. So when there is no onus to a public resource, anybody can use it. Nobody will use it wisely because it's a resource which is available, and there is nothing they lose. There is no accountability. So getting new antibiotics is probably not the answer. The second thing is, you look at the economic side of things. We have the Chamber of Commerce here and all that. Antibiotic investment doesn't give results. Now, I invest in an antihypertensive drug, which I spend billions of dollars or rupees developing. And I diagnose a person at the age of 45 to having high blood pressure. He uses this medicine for the next 30 years. So this one person is able to generate so many years of usage. And imagine the more number of people are diagnosed hypertensive, the company which has invested billions can reap rich rewards. So it makes very good economic sense to invest in something. It could be an antihypertensive, it could be an anti-diabetic, it could be an antipsychotic, it could be medicines used for erectile dysfunction, for example. These will work, people will be clamoring for it and buying it. Whereas coming up with an antibiotic with millions of dollars or rupees in research is not economically viable. I spend, say, 100 crores and come out with a molecule, and in a matter of 2 or 3 years, this molecule goes waste because antibiotic resistance develops, and I can no longer use the antibiotic. 2, antibiotics are used for short periods of time, 1 week, 10 days. We are looking at lesser and less usage. So which means the company which is investing money is not going to get the rewards. And 3, ever after you come up with the antibiotic, if it's a good antibiotic, everybody says, oh, don't use the antibiotic, use it very, very minimally, use it judiciously. All of this make investment into coming up with newer antibiotics economically a suicide. So coming up with new antibiotics will not work unless the government is going to back up and come up with funds for this. Coming up with new antibiotics will be irrelevant because the resistance happens. It's like there is no solution to this. Just like there is a There is no solution to the Cold War. There is no solution to the population explosion. There is no solution to the tragedy of commons, because it will not be able to sustain and solve the problem. So for these reasons, research into antibiotics is definitely one of the solutions you look at, but that is not going to solve the matters. Using antibiotics wisely, ensuring that the culture of antibiotic usage changes, coming up with disincentivization of antibiotic usage, probably these things will be the answer in the long run.
Thank you, Dr. Ramasubramaniam, because we cannot depend on this. This innovation gap is really very glaring gap now, and this is concerning. And moreover, one more thing, that expertise to discover these medicines is also lost over the years. 1960, when these antibiotic were, different classes were being introduced, at that time, the clinicians made the claim that we are no longer worried about the infectious diseases, and perhaps that was the time people or the industry stopped investing in the antibiotics, and we have over the period lost that expertise also. But one thing that we all see glaringly, glaring at us is that now we have, triple burden of the disease. Infectious diseases are there. We have further compounded it by adding MDR and XDR. We have a burden of non-communicable diseases, diabetes. India is the diabetes capital, and these people are immunosuppressed, more chances of getting infected, more chances of, getting, problems because of these infections. And the third dimension in metros, the road accidents, deaths due to young people dying because of this. So that's the kind of burden. So all the more reason that we use these antibiotics, because no new ones are coming. We need to use this precious resource carefully so that we can use it for longer time. The logo here I use is more you use, more you lose. Because less effective it becomes. Can I jump to Dr. Rangareddy, because we are discussing about alternatives to antibiotic. You've been working on alternatives to antibiotic. Are there any other antibiotics alternative available to us which can be used, or there are none, or there are few in the pipeline?
See, when we talk about the alternatives, which has been a subject which we touched upon in our policy advocacy document for G20, where we very clearly talked about alternative diagnostics and alternative therapeutics. Just taking cue from what Dr. Ram talked about. See, altogether eliminating at this moment our reliance on antibacterials is near to nil, because there are certainly a lot of alternatives, and we certainly need to lessen our dependence on these antibacterials. Otherwise, we would be, only escalating this problem. There are, medical and probably non-medical interventions, which we had to talk about as a counterweight to the antimicrobials. When we talk about non-medications, that is, proper infection prevention and control, the antimicrobial stewardship, what you're talking about, and other means. But when we talk about alternatives in terms of the products, there are definitely many in the pipeline. They are, some of them are 100 years old, like bacteriophages, which you also wrote about, several articles as an alternative. But the problem with all of them is, the regulatory scenario is not conducive. And the kind of investments what had to happen into these alternatives, they are not viable investments, right? Like it is not viable to invest the money by private players into developing the new antibiotics. It is also not viable to invest into, let's say, bacteriophages or proteins or prebiotics, plant-based substances, etc., etc. It is a long-run process, and also at the end of the day, probably seeing the light at the end of the tunnel would also be difficult. And the most important is, like antibiotics, they may not find an universal acceptance. And antimicrobials, they had a universal acceptance because all the systems are standardized. But in the case of, let's say, individual proteins or small proteins, they call it as, or bacteriocins or bacteriophages, it is very, very difficult. So, and hence the investment strategy had to be, like Dr. Ram has very rightly mentioned, the responsibility of the investment had to be on the government, and also probably some of the philanthropic organizations, right? Luckily, that is happening. It is not that it is not happening. For example, you look at our own DST, where I am also part of the advisory council to vet various projects actually to identify the alternatives to antibiotics. There is a lot of government funding which is given as a grant in order to develop them. You also have Fleming Fund, etc., etc. So all these things had to be much more quicker, much more efficient, and also time bound, so that is going to incentivize the people and also stimulate the researchers in order to get all these alternatives. They are very much required. I would underline once again that if we are going to stay on the path of complete reliance on the antibacterials, we are going on the wrong path. We had to definitely develop these alternatives. One of the things, which I am gung-ho about, I have written several articles about it, bacteriophages. Although, they are very specific to bacteria, but definitely it is suited for certain applications. We need to develop them. There are various researchers across India, who have got now the banks of bacteriophages. We need to actually incentivize them. We need to give the proper kind of guidance and also the money so that they can go on with the research and bring those products as quickly as possible into the market. I'm confident that these kind of initiatives by the GST, the DST, and also the Fleming Fund and CCAMP and others, I'm sure it is going to catalyze that process, and a lot of our own indigenous solutions, which are not based on the antibiotics, would see light very, very soon. I hope next 3 to 5 years horizon, we will have a lot of them. Thank you.
Thank you, Dr. Rangareddy, telling us the current situation. Although research is needed, definitely needed, more investment is needed. But as you know, it is a long drawn process. It takes, 10, 15 years time, billions of dollars, efforts, research activity. We are hopeful that we get soon, but I think, again, it brings back to the same solution that we need to save the existing one, rescue the existing antibiotics, and that would be by optimizing their use. With this, I would like to move to Dr. Anup Warrior. Because there are definitely, within our armamentarium, there are various alternatives that are not enough, explored in the way they should have been, explored and used for patient management. And also there are a lot of ethical, legal concerns, and antibiotics, how they are a different class of medicine. They are not same as paracetamol or antihypertensive drugs. They are the drugs which, where individual use of this medicine can impact the society. So, Dr. Anup Warrior, can you just, because we cannot leave that the problem is there, but we need to come up with the solutions as well. How do we go about it in the current scenario? Elaborate on alternatives that you use and your experience about this, the legal, how do we, take care of these ethical concerns?
So, regarding the ethical concerns in practice of stewardship, I would like to take it at 2 levels. One level is between at the prescriber level. The prescriber level, because the prescriber has to make certain judgmental decisions, like what you mentioned, does his decision weigh more on the societal benefit of addressing AMR, or does his decision benefit the individual who is right there in front of him, suffering from whatever infectious disease syndrome he might have? So in that perspective, to navigate that ethical consideration or a challenge for the prescriber, that do his decisions target or focus on the patient who is in front of him, or how much of the perspective of societal benefit or harm from the antibiotic use has to come. A lot of this has to come up from one, the public awareness part, because some of them is based on need-based thing, and we know, for example, when you are discussing about COVID and how the development of vaccines or changes or interventions in COVID was very fast, and it happened within few things and all. A lot of it was because the patients or general the public also demanded that. So one of the things which would help prescribers navigate this ethical thing is about the public awareness and the patient's understanding that so somebody has an upper respiratory tract infection, it is okay to wait for 48 hours to see whether it subsides, or wait for a couple of days for a while, and not to, you did not give me this, so that is why the fever is not going, etc., etc. So the public awareness is one aspect of addressing that. The second is in the core medical training, from the core medical education itself, because as prescribers, we make a lot of clinical diagnosis or provisional diagnosis, which cannot be shown or proven or substantiated with laboratory tests. For example, even in an outpatient on a simple acute febrile illness, the kind of test we would need to order, we would not order, or when we make a decision that yes, we can observe you with 2 days of paracetamol instead of ordering a blood culture at the first day of fever when he comes to the OP, or prescribe him an antibiotic at the first instance. When we make that, it is purely on the clinical acumen or the clinical diagnosis or the provisional diagnosis. So the second way to address this ethical consideration of whether to weigh more on the patient safety side or on the societal side is to build up the competence in terms of making clinical diagnosis, making the right sort of clinical judgment, having that acumen to make the clinical judgment on a day-to-day basis for the bedside patients. End of the day, I think as clinicians, most of us would err on the side of making a decision for the patient. So unless, as Dr. Rangareddy was mentioning, the term enabling environment, until the enabling environment sort of supports decision making on the societal perspective, like I know that for a fact that in Europe, in certain countries, ICU utilization is decided by the doctors. So they decide whether for this particular patient ICU bed is required or will benefit. If not, they say that okay, he is hospice care and not intensive care. That is because the legislation and the enabling environment supports that decision making. So in India, it is not. It is the patient's prerogative. If he says that I want ICU care, I want everything, I want to be ventilated, intubated, I want all the best antibiotics, he has the right to get it. Okay, so the third thing in this perspective is about how do you build that, as Dr. Ranga has mentioned, the enabling environment which will substantiate, support, and promote the decision making, which is balanced for both. Obviously, we don't want to sacrifice the individual for sake of societal this thing which may happen later. So how do you make that this thing so that this balance is in the right thing? The second ethical consideration is at a different level, where as a hospital management perspective, we need to take the thing of the prescriber versus the steward. Right? The prescriber has certain needs and requirements, and the antibiotic steward has a different set of needs and requirements. And as the hospital management level, how do you take the right decisions? So who is right? Is the prescriber's perspective of, as we mentioned earlier, doing this is the right for the patient, or the steward's perspective is right? So that again is those questions are at a different level, and they have to be answered again in terms of as the topic today on the business case, because there we can't talk about the right or wrong in terms of clinical right or wrong. Right there, the right or wrong means many other different things, not just the clinical practice. So these are the two aspects which we need to iron out.
Yeah, very rightly said. This balancing act is needed. I always say we have learned how to prescribe antibiotics, but we need to know when not to prescribe. But then the question comes, the clinician, for him, the immediate priority is that individual patient, but we know that it has a public health impact, community. So all that time, that balancing act needs to be done. And moreover, during COVID time, if we don't regulate ourselves, we saw that lockdowns happened, and they had a devastating effect on affected everyone, each one of us. Perhaps we don't want to get into that situation again. Or we see the example of TB, how TB was managed. We had this standard regimens for decades, but still, even we today we find different regimens are being used, or patients are not getting the entire duration. So that's what is leading to MDR. And if we, that's why, government had to come with legal provisions that it became a notifiable disease. Then again, people did not listen. They still went on doing what they were practicing. And then now the penal actions have been, jail terms has been introduced. So I hope none of us want that kind of situation. Again, we need to regulate ourselves. I will go to the questions. There are a few very pertinent questions in the Q&A box here. Rahul, quickly, briefly, can you tell the best practices that being followed in CAHO, and then I'll move to the question and answers.
Yeah, we used for certifying this hospital as a center of excellence. We used CAHO, that is Consortium of Accredited Healthcare Organizations. There in 3 steps were virtual self-assessment and physical audit. We audited all these hospitals and certified them as center of excellence for infection control and antimicrobial stewardship. This certification demonstrates leadership commitment, and it serves as a this certification serves as a tool, as a guiding tool for the other healthcare settings to follow the AMS and IPC programs. This ensures that there is a things becomes easy when the SOPs and the protocols gets integrated into the quality management system of the hospital. So CAHO certification helped us to build up, to integrate these SOPs and protocols and ensure there is a strong compliance towards the program. There is a leadership commitment. There is a fixed budget. And there's a monitoring evaluation mechanism to monitor the indicators like rate of infections and resistance patterns. So that was the benefit from the CAHO certification.
Dr. Anup Warrior, you are also running a Center of Excellence certified by IDSA. So anything specific you would like to mention here?
So very briefly, what it helped us was that it, just like any accreditation, it gives you a direction on which to go. It gives you a very structured approach in terms of what are the processes which has to be monitored, what are the outcomes which has to be monitored. It also lays open certain gaps which, when you approach that in fashion, that pops out. And very, very importantly, it also gives the management of the hospital to look forward to for something, right? After they, like I told you, it's a manpower intensive thing. So when they give me manpower, when they give, what do they get out of end of all this? So it gave them something to look forward to, that investing in people, investing in processes, and all end of the day, they get an international accreditation, which sounds good to all of us.
Okay, I think, Dr. Ranga Reddy, quickly, can you, can we have some public-private partnership to take this program further? What are the opportunities for public-private partnership?
I think absolutely. I think, it is not only public-private partnership in one sector. We need this partnership across, you mentioned it, actually, across the sectors, especially in regard to the human health sector. It is most important to bring all the stakeholders together. I would take just one example of the quadripartite antimicrobial resistance multi-stakeholder partnership platform, which has been created by WHO, OA, UNEP, and other organizations very recently, where about 140 organizations across the world have come together, from academia from the healthcare institutions, the private organizations, civil society organizations. So this kind of platforms, what they would do is they will enable basically, cross-pollination of the ideas. The cross-pollination of the ideas and the collaboration is the mantra if we really want to kind of contain this wildfire-like issue called as antimicrobial resistance. Unless we are going to have the knowledge transfer, knowledge sharing, and the networking, we will not be able to solve this problem. That is definite, right? I think, there cannot be any questions on that, because unless, we are going to address much more holistically the growing threats and impacts of AMR globally, because we cannot again look at it as a compartmentalized problem of a particular state or a particular city or a particular country. It is a global problem. We need to have the global approaches. More of such discussions, roundtables are required. My kind of appreciation for IACC actually to bringing this topic beyond the four walls of the healthcare system, because this need to be discussed in the public forums where even the patients, even actually other who are otherwise not concerned with the AMR need to be brought in. And this public-private partnership, when I say public, I don't mean the government. The public, when I say probably, I would say it is the people who are the biggest affected kind of strata. We need to bring on them, and definitely then the whole issue is going to get resolved. You know that very well. In April this year, there was a document which was built by all these 140 stakeholders, what I talked about, which is going to be discussed in UNGA in September, where they are precisely talking about actually the partnerships and the platforms, right? And in September, you would see actually the document coming. Recently I shared actually in all the platforms the initial draft, which says that we need to bring all the sectors and we need to own up the responsibility. We also need to bring intergovernmental organizations and also the youth and indigenous people also into actually this stream in order to find a comprehensive solution to the problem called as antimicrobial resistance. Thank you.
Thank you, Dr. Rangareddy. I think now I will open, this is, for all the panelists. There is a very important question in the Q&A box. Somebody has asked, we have discussed about the secondary care, tertiary, quaternary care. How do you regulate? How do you implement this AMSP program in smaller clinics, smaller nursing homes like places? Any one of you, if you have any idea, although all the principles of AMSP apply on them, but just because they're working in a small scale, they may not be having enough, expertise to guide them. They may not have the supporting diagnostic labs with them. How do they go about it?
Dr. Sangeeta, I will volunteer,
Okay.
maybe. I think one big intervention, I also already wrote it in Q&A also, that the mandatory indication before prescribing, right, any antibiotic, that is going to make a ocean of change. However small, the clinic is, even if it is a independent single person kind of practice, if that person, that particular prescriber and practitioner is going to first put a diagnosis and then start actually prescribing the antibiotic, it is going to make all the difference. You may not have the diagnostic lab very well equipped there, it doesn't matter. What matters is put a diagnosis first, even before you start penning your antibiotic prescription. I think that is one.
Yeah, because most of the time, if you look at the decisions are made on clinical basis only. if you are if we revive that art of taking the good history examination, most of the time we can make out. And bulk of the presentation in the outdoor department is upper respiratory tract or diarrhea or things like that, and where we can distinguish between viral and bacterial clinically, or you may use some scaling criteria for categorizing them into viral or bacterial. So that is one thing that I think smaller hospital can do, or they can join hands, adjoining hospitals. If they have AMSP committees, they can join with them. They can share their antibiograms. They may not have their own, but they can be shared. It may not be very much different for them. Okay. Now this takes me to second question. Dr. Anup or Dr. Rama, if you can take this. This is regarding TB treatment. Is an algorithm like TB useful, where treatment is only after test result? For MDR TB, being stringent with testing helps in saving the reserve antibiotics. However, irony might be that the same reserve category antibiotics are being used in other cases, resulting in resistance. What would be our experts' opinion? Can such an algorithm work at least for hemodynamically stable cases?
Yeah, maybe I'll take this question. Yes, absolutely. Clinical practice algorithms customized to the local scenario will make a huge difference. And I'm a huge fan of, as an infectious disease consultant, the importance of diagnostics in treating a patient. In fact, we have paraphrasing Vince Lombardi, who I can say that diagnosis is not everything, it is the only thing. So you have an algorithm based on diagnostics. TB most often does not warrant an emergency treatment. So you diagnose the condition, find out what kind of resistance profile it has through rapid tests. A lot of them are now point of care. So using point of care, hopefully less expensive diagnostics, and creating a flow chart, an algorithm for treatment will make a huge difference in using antibiotics wisely.
Yeah, very rightly said. Then there is another question. I think we had been discussing this, but all throughout the panel discussion, how to deal with VIP patients and star prescribers. Open to, that's the problem that each one of us face in day-to-day practice.
You want to go, Anup?
Just like how you deal with everybody else. In terms of clinical practice, let us stick to good clinical practice. Yes, in the ways and means of communication, how intensively you want to communicate, how do you want to communicate with them, who has to communicate with them, that might change. Because when VIPs and have a different strata and they have so many questions, you have to convince different people, that's fine. So your communication strategies in all ways, like how do you want to talk about it, who has to do this, etc., might change. But in the end, the clinical practice should not change. That's my opinion, and that's how I do it.
Dr. Rama?
Yeah, just to add to that, that's perfectly true. I think what in at least hospital setup, you need the administration to back you up. If your administration stands by you, whether it is a VIP or a VVIP, it doesn't matter. You do science, you do evidence-based practice, and there should be no questions whatever anybody demands, as long as they back you up in a hospital setup. Yes, I think that's it.
We have Dr. Upasana Arora also with us, and she is heading this Yashoda Hospital. How do you manage VIP patients? I'm sure you must be getting a lot of VIP patients there.
Thank you, Sangeeta, because my hospital is all the time filled with all the bureaucrats or politicians or sometimes very rich businessmen. But basically, we are always with our doctors and we never interfere with their clinical things. So that is how, because they are, as my previous colleague said, that we are science-based, we are doing ethical practices. So that is how we are able to, and I have a good friend like you who are guiding us time to time how to use, antibiotics. And because of NABH, we are doing continuously audits. So it's very good practice in my hospital. I have a question from all of you. I just wanted to know, is there any law coming in India? Like I have heard a lot that there is a law is supposed to, coming that we cannot get antibiotic on counter, that I will go and ask for, because everyone is just from day one, they are asking for augmentin. So is there any way, kindly answer me, any one of you who are really working near to government? Yeah, please.
Maybe I can take this question. In India, the melody is that all drugs are prescription only drugs, but yet all drugs you can get over the counter, which includes the antibiotic, right from amoxicillin to high-end reserve antibiotics. Anyone can go and buy that. So we understood this problem and we wanted that pharmacy not to do this over the counter, penalize him. But then we saw that it doesn't work because it is affecting their business. Because they are earning out of dispensing these medicines over the counter, and they don't want to turn away their patients from their pharmacy. So in 2013, Schedule H1 was enacted, which the government tried to say, okay, if you cannot prevent over the counter dispensing of all the drugs, at least these 11 antibiotics and some habit forming and some anti-tubercular drugs should not be dispensed over the counter. You have to keep a record of these dispensing, register in your pharmacy or hospital, wherever these are being dispensed. This was in 2013. This is called Schedule H1. But unfortunately, even after 10 years, a decade of having this enacted, this also is not working. Awareness, even, if I ask the clinicians, are they aware? If I ask the hospital, they are not aware of this Schedule H1. And even if they are aware of this, but they are not, sure what records to be kept. Now, this is a very debatable area. In our country, there are a lot of informal prescribers as well, and over-the-counter dispensing is also happening. So, there is a suggestion coming up that maybe you cannot stop this completely, but you can restrict it to, you may allow some excess group antibiotics, which, can be used over the counter. But certainly watch group and reserve group antibiotics should be dispensed only on prescription. I think this dream is a utopian dream, looks like that. But we have to be optimistic here because, as usual, the government is an elephant which moves slowly. So perhaps someday, something, will move and will be. And, Dr. Rangareddy, Dr. Rama was mentioning about OTC, they have, enacted these laws. So let's learn from them. How is their experience going about it? And then it can be perhaps extended to the entire country. Mr. Pankaj Bora, you have raised your hand.
Yes, Dr. Sharma. In fact, I was going through Q&A box and many of our participants were keen to know how this AMSP would result in cost savings. Though partly Dr. Sanjeev Singh has replied in his presentation, but if any of other panelists can throw some light on this, what kind of cost savings can be achieved by the smaller clinics by adopting or implementing this AMSP?
Dr. Rama, Dr. Anu, would you like to take this? Yeah.
So regarding smaller hospitals, I don't have a clue. But when it comes to the larger sector, so there are a couple of things which will determine this thing. First, what cost saving are you talking about, to the patient or to the hospital? Okay, so that's one perspective, because
Let us take both.
And the second thing is that also who is the payer? Like, is it's out of pocket paying for the patient? Is it a private insurance with bundle this thing with exclusions not there? Is it an insurance scheme? So first thing is that when you look at all these publications or data in terms of cost savings and all, we need to there are two major variables. One is what I mentioned, like for cost saving for whom and who is the payer. The second is that most of them, again, when Dr. Sanjeev was mentioning, Dr. Sangeeta also talked about it, that they talk about opportunity cost in terms of savings of average length of stay. But we should understand that that is applicable only if the hospital is jammed full and doesn't have any beds to spare. Okay, so this opportunity, once the occupancy of the hospital falls below 80s and down, 75, 80 and all, they actually have a beds to spare. So there again, this calculation of average length of stay reducing by 2 or 3 days, and then the opportunity cost doesn't work. So in two situations, there are definite cost savings. Okay. One, when there is a bundled payment system, that means for a particular service, you get this much money, and the payer is not going to be an out of pocket, like who's going to pay out of it. It's an insurance fixed sort of sum. So then when you reduce your prophylaxis, then you use better targeted antibiotics in your critical care or your post-operative patients or even in your medical patient, etc. Then there is cost saving. Cost savings for both for the hospital because they are going to get only fixed thing, and for the patient because he will not end up paying additional out of that bundle this thing there. The second area where again this cost savings is when the hospitals looks at procurement cost. So many of us, including us as a corporate, we look at procurement cost. So we want to reduce our procurement cost from last year. Like so, last year if my pharmacy spent 10 lakhs for buying drugs, this time our teams we want to spend a bit less in terms of this material cost or procurement cost. There again, when you look at the overall antibiotic consumption and the pattern of consumptions, etc., and we are able to bring down the consumption, it saves at the material cost and for the hospital. So these are the only two areas where at upfront I can see how cost savings would be affected. This length of stay bit and all is bit tricky.
Yeah, that's fine. So if the cost saving is accrued to hospital, that will automatically be passed on to the patient in time to come.
Yeah, would you
Dr.
like?
Singh?
Yeah, Dr. Rama, would you like to add?
No, I think Anup has said very, very succinctly. But what I want to convey is, please remember that antibiotics are limited resource. And when you use antibiotics, you not only affect the person in whom you give it to, but you affect the entire community. I may use an antihypertensive medicine, I may use an anti-diabetic medicine. It's going to work only on the patient in whom it is intended. But when I use an antibiotic on a person, the microbiome or the bacterial profile in his body is changed. This reaches community through the earth, through the sewage, through the waterways. This affects the poultry, this affects the sericulture, this affects the farming industry. It affects the entire community. So without even taking antibiotics, I consume chicken which has been exposed to antibiotics. The chicken has genes, bacterial genes which carry resistance. I can end up having a resistant bacterial infection for nothing to do with me. It is because somebody used antibiotic in the community somewhere far away that I am paying the price. So using antibiotics wisely is something which everybody should be responsible about. It's not hospitals, it's not pharmacies, it's not doctors. Everybody is responsible because it affects all of us. It is not cost savings just in that person, in that hospital, in that month. It affects entire population. If India is having a problem, in a matter of a year or two, US is going to have the problem. The entire world is going to have the problem. We have to realize it. And I think that is more importantly an active cry to make sure that we all adhere to judicious use and stewardship initiatives and make sure that we use antibiotics wisely.
Germs are more global than us, they can, travel in no time. We saw COVID, how it within no time it spread to the entire globe. And similarly, these resistant germs, they don't know the boundaries, so they will travel. So today we may not be affected, but tomorrow it will be certainly there. There is one pertinent question for both Dr. Anup and Rama. How do you convince doctors to de-escalate? That is one of the strategy for optimizing the use of antibiotics, but convincing the doctor is the most difficult task, particularly if you can address the de-escalation part.
I'll be very brief. One, to ensure de-escalation, you need to have a correct diagnosis. So make sure your diagnostics are in place and the proper diagnostic tests are used by the doctor so that you are in a better standing. 2, you have your hospital antibiotic policies based on your local antibiograms, your local bacteria, your local susceptibilities, which is evidence to say that this is what should be done and the administration should back you up in this. And 3, this, as I said, is an emotional sensitive issue. You need to have a dialogue. You need to have a discussion. And sometimes winning the war is more important than winning the battle. So you may lose a couple of battles. You may compromise a little bit, but in the long run, you need to ensure that this is brought back on. That's it. Over to you, Anup.
In short, it's personal connect and administrative support. So this, in short, just these two things: personal connect with the prescriber and administrative support when it is required. That's all.
One related question in the Q&A box is how steroid use, maybe it was little outside the area of today's panel, but how do you restrict that?
Steroids don't affect the entire population. Steroids affect the person. So if you make a mistake, you probably cause a problem for the person. That's it. Whereas antibiotics are otherwise, have global impacts.
Well said. I think, yeah, that's very good. But still, steroid will reduce the immunity, so will make your patient more vulnerable to catch these infections. So the patients who, we saw that COVID patients who died, those who got high dose of corticosteroids, because we made them vulnerable to these infections. So actually we did harm to the patient by prescribing these steroids. There were other related questions like how do you, Dr. Rangareddy, there is one question, maybe you can quickly respond to it. What is it being done to expedite the availability of newer antibiotics or alternatives to antibiotics?
As I mentioned earlier, I think, there are a lot of initiatives which are taking shape on 3 directions. The direction one is novel antibiotics, which are done mostly by the pharmaceutical companies and the innovation incubators within the universities and also the individual researchers. Of course, the horizon of them seeing the light is quite longer. But the second part of antibiotics with combinations. Combinations, for example, you take the example of actually amoxiclav. It is amoxicillin clavulinic acid, which actually makes much more efficient in terms of its treatment. So such combinations, such adjuvants being added to the older antibiotics in order to rejuvenate them. Such research is happening. I am sure, in next couple of years, we would see such adjuvants coming with the older antibiotics rejuvenated. I'm sure, that is going to be a good stream, which is going to happen. Third is the alternatives, what we talked about, all the kind of bacteriophages, proteins, bactericins, etc., etc. There is a lot of thing which is happening. I think in next couple of years, we are going to see that particular area maturing, and we will see a tipping point that, you please mind this word tipping point, which is going to happen probably somewhere in 2025, when a stream of these alternatives are going to hit the market, and that is going to make our fight against antimicrobial resistance much easier. And it is also going to provide to the clinicians with alternative armamentarium or the weapons actually to deal with infections much more effectively. I hope I could answer.
Yeah. The expedited approval processes have been advocated
Absolutely.
for these
Yeah.
antibiotics so that they are made available. Those bureaucratic regulatory constraints are, less stringent for these antibiotics, but yet, we need to see to it.
You are absolutely right, Dr. Sangeeta. Nowadays, both US FDA and also our own DCGI, Drug Control General of India, they are actively considering the in silico clinical trials. In silico, that means using the digital technologies like artificial intelligence, machine learning, etc., in order to expedite the clinical trials and also reduce the time and cost related to these clinical trials. That is going to make these products coming into market much more faster, much more efficient, much more cheaper. Thank you.
Thank you, Dr. Rangareddy. I think we have overshot the time, but I believe the participants here did not mind staying there. I could see in the participants, many of our colleagues are also, there, well known. Dr. Ashok Ratan, Dr. Anita Arora, Dr. Chavi Gupta. There are lots of names which were familiar. But anyway, I will just take, quickly. There were one or two questions which have been answered in the Q&A itself regarding the reaping the benefits of AMSP. Initial gains, you may find a steep, gains here, but as you grow or as you consolidate, one thing that we need to see is that we need to sustain these. Having achieved, reduced length of stay or some other outcome will not be good if we just after that, we become lax and we forget about it. We need to have measures in place so that we sustain these gains. And I think this is what challenge is for the Dr. Rahul Kamble as well. He has been able to demonstrate that this can be done in the secondary level care. He had to definitely do a lot of hard work, but now the challenge remains that whether we are able to sustain this. And just quickly, I will just share my screen and quickly just pass through this to sum up the session here. Can you see my screen? At the clinician level, if I have to say, they are too busy for improvement. We need to change our mindset. We are, somehow more tuned to fighting today's crisis, but we are not able to plan for our future. But this is one area where AMSP can help you in improving the patient outcomes, safety, without, and it will save you a lot of time for other patient care activity. And in terms of, I think most of these participants today are from accredited hospital. So, and you need to sustain that. And you cannot say that I have a quality, but it is not safe. Quality and safety go hand in hand. You cannot say that you are quality JCI accredited, NABH accredited, or NQAS accredited, but if your patients are getting infections, hospital-acquired infections, it is also not a question of one team working against the other. Many a times. Many a times, we are working in silos, nurses working separately, different discipline doctors working. So this is one area where we all need to get together. So that is why AMSP, you cannot, deal with it unless you have a multidisciplinary group working on it. And you have to have an integrated approach here. Data is needed, integrating, you need to integrate antimicrobial stewardship program with the diagnostic stewardship. Unless a diagnosis is made, I think all other subsequent steps will be lost. And IPC is something that we need to continue investing on. Prevention is better than control, cure. So we need to prevent that. We need to share best practices. Today we tried to do this in the panel discussion, have champions of these, and which can spread this word. And definitely leadership is very important. Many of you are from the private sector. You need resources in terms of human, financial, IT, multidisciplinary approach. You need to use some data analytics, latest digital systems. All this can be done only when you have a leadership support with you. Otherwise, all efforts will go in vain here. And as I said earlier, we need to continue investing in education, and enabling environment. We need to create a culture where everyone feels safe, including the doctors. Toxic environments or where there is a dependence on supervision, this can all lead to adverse outcomes, poor leadership. So I think this is somewhere that we need. This is the soft part of it. I can't say anything about this, but investing in antimicrobial stewardship is not only a moral imperative, but it is a business case as well. I think most of you would understand this, that improving patient outcomes. We are all here for patients, and the one and only main objective of the entire healthcare is to improve patient outcomes. And this is one approach where you can improve upon the patient safety and still strive to maintain good quality and rise further, reduce cost, and demonstrate your commitment to quality and safety. That's all with this. I think.
Sangeeta ji, let me come in.
Yes, sure, please.
So, as a healthcare chairperson, I would like to ask my president, Mr. Bora. I would like to, this year, I want to start one award exclusive for healthcare, where we will have some quality criteria, which we can do easily with the help of my experts, what criteria we should do. And then we will ask for the participation, and we will award the best hospital. If you agree, sir.
Yes, of course, this is a very good idea. We should go ahead it, but we will have this point formalized through our process of approval through the board of directors. So we'll do it, but this is a really, really very good idea. We must recognize the good work of in the medical profession, and whosoever is doing wonderful work, we should use IACC platform to recognize their efforts.
Sure. So Sangeeta, you can carry on, please.
I think you have summed it up. There is an incentive to invest in AMSP. So perfect business case now, because motivation by giving rewards is one way of motivation to continue working in it. And I think if you are a IAC is able to do it, wonderful. And I believe public hospital also, will also take part in it and will do it. I think with this we can conclude. Irrational combination. I think the question is about irrational combination. A lot of combinations which were irrational have been banned after a long legal battle. And out of 350 drugs which have been banned in our country, 96 were antibiotics. But I still believe there are many more irrational combinations which are available. So our drugs control authority needs to be really, continue this vigilance on and continue, banning these irrational combinations with our lot of, interventions now. The power to license a new drug. Earlier, each state drug controller had the power. So many of these irrational combinations creeped in because one or the other was unscrupulous. But now this power is vested with the CDSCO. So perhaps this should not be a big.
I think this topic is very long and we can go on and on, but
yes,
we need to think about timing also. So with these words, I think my vote of thanks to everyone. And thank you, IACC, and all the participants, and special thanks to my dear, all those panelists who came here. And Kamalji, you can formally close this conference.
Yeah. As somebody said, all good things have to come to an end. We're very fortunate to have this kind of a panel. People. There were doctors from quite a few other cities. There was somebody from Faridabad, from Kochi, from Chennai. And we're more fortunate that we have Dr. Upasana as our chairperson for the committee and Dr. Sharma as our co-chairperson. Thank you very much to all of you. And thanks to the audience as well. We have seen that many times. We have seen that usually towards the end of the event, the audience dwindles. And kind of go away, but I've been noticing, from the time we started till now, we have not lost that many participants. So thank you all. Thank you, everybody.